Your doctor put you on a beta blocker for blood pressure. You've been taking it faithfully for years. You feel tired. You've gained weight. Maybe you slowed down and you thought that was just aging. But what if the pill itself was the reason? Think about that for a moment, because it matters enormously. Over 40 million Americans over 60 are on beta blockers right now. 40 million people, and a growing number of cardiologists are quietly asking, should all of them be on these drugs? My name is Dr. Kevin Adewale. I'm a cardiac surgeon with over 20 years of experience, and today I want to have an honest conversation with you, the kind your doctor may not have had time for in a 10-minute appointment. Beta blockers have been around for over 60 years. The very first one, propranolol, was developed back in 1964. At the time, it was genuinely revolutionary. Scientists discovered that blocking certain receptors in the heart could slow the heart rate and reduce his workload and reduce the force of each beat, bringing blood pressure down significantly. Doctors were genuinely excited and, honestly, they had every reason to be. Through the 70s and 80s, beta blockers became the go-to drug for high blood pressure across the entire Western world. If a patient walked in with hypertension, a beta blocker was often the very first thing written on the prescription pad almost automatically. It felt safe. It felt proven. It was what every major medical school was teaching year after year. The problem is, medicine learned a lot since 1964, and the science moved in some surprising directions. And some of what medicine learned didn't automatically make it back into every doctor's office. That's the gap we need to talk about. Here's the simple version of how these drugs work. Your heart has receptors. Think of them like little switches on the surface. When you're stressed or physically active, your body releases adrenaline. That chemical flips those switches and speeds your heart up rapidly. Beta blockers block those switches. The heart beats slower, pumps with less force, and blood pressure comes down. Sounds perfectly logical, right? And for certain specific conditions, it absolutely is the right approach. I'll come back to that. But here's the thing. When you're 60, 65, 70 years old, your cardiovascular system already works very differently than it did at 40. Your resting heart rate is naturally lower. Your blood vessels are less flexible and elastic. Your kidneys process medications much more slowly. What works perfectly in a 45-year-old body can behave very differently, and sometimes harmfully in a 68-year-old. And that difference matters enormously. Does that make sense so far? Because what I'm about to show you is where this gets really important. For a long time, the evidence for beta blockers and hypertension looked very solid. Doctors trusted it. Patients trusted it. Nobody was asking questions. Then came a landmark study that changed everything. The ASC-GOT trial, the Anglo-Scandinavian Cardiac Outcomes trial published in 2005. It compared beta blockers directly to a newer class of blood pressure drugs called calcium channel blockers in a large group of hypertension patients. The results were so striking, so clear that the trial was actually stopped before it was scheduled to finish. Early termination patients on the newer calcium channel blockers had significantly fewer strokes, fewer heart attacks, and a notably lower risk of developing diabetes. The beta blocker group didn't just perform worse, they lost by enough that continuing the comparison felt ethically wrong to the researchers. After ASCOT was published, major medical organizations around the world started quietly updating their guidelines. Some moved faster than others. The British hypertension guidelines moved beta blockers off the first-line list for uncomplicated high blood pressure. That's a significant change. Other European guidelines followed. The American guidelines became significantly more cautious about routine use in uncomplicated hypertension. But here's the critical gap that genuinely concerns me as a practicing physician. Guidelines change in medical journals and textbooks. They don't automatically change what's already written on your prescription. That renewal just gets processed. Nobody reviews it. Millions of patients who were started on these drugs 5, 10, 15 years ago, they're still taking them without anyone questioning why. Their doctors are busy. The prescription gets renewed in the system. Nobody stops to ask, is this actually still the right drug for this person today? That is not a criticism of individual doctors. It's an honest reality of how modern healthcare systems work under pressure. But it does mean the burden sometimes falls on you, the patient, to bring this question to the table. And that's what today is about. Let me tell you something I hear constantly from patients over 60 who come to see me after spending years on beta blockers for blood pressure. Almost every single one of them says the same thing. I just assumed I was getting old. I thought feeling this way was normal. The fatigue is real, and here's exactly why. Beta blockers slow your heart rate. That's precisely the mechanism. But a slower heart pumps less blood per minute. That means less oxygen delivered to your working muscles. So when you try to climb stairs, walk to the mailbox, carry groceries from the car, your body simply cannot respond the way it used to. Your heart is physically prevented from speeding up the way your muscles are demanding. It's like trying to drive uphill with the engine electronically capped at half its normal power output. You push the accelerator, nothing happens. And here's what makes this particularly cruel and hard to recognize. When older adults feel exhausted doing physical activity, physical activity is one of the biggest accelerators of aging and cardiovascular decline. We know the drug prescribed to protect your heart may actually be setting off a slow chain reaction that ultimately harms it over time. There is a clinical term for what I'm describing. It's called exercise intolerance. Studies consistently show it's significantly more common in older patients on beta blockers. Let me ask you something directly right now. If you're over 60 and taking metoprolol, atenol, or bicoprolol for blood pressure, think back carefully to when you first started. Did your energy levels change? Did you slow down? And did you just quietly accept it as a natural part of aging? You are not alone if you did. Thousands of people every year make that same assumption, and that answer matters more than you might realize. Now here's a side effect that really doesn't make it onto enough conversations between doctors and patients at routine appointments. Beta blockers, particularly the older generation like atenol, are measurably associated with an increased risk of developing type 2 diabetes. How much of a risk increase? Studies show approximately 22% compared to patients on alternative blood pressure medications. That is not trivial. 22%. That's nearly 1 in 4 additional patients developing a serious lifelong chronic disease they might never have gotten otherwise. A disease that damages your kidneys, your vision, your peripheral nerves, and your cardiovascular system, from a drug they took specifically to protect their cardiovascular system. The mechanism behind this is actually quite well understood. Beta blockers interfere with how your pancreas releases insulin in response to blood sugar. They reduce insulin sensitivity in muscle tissue, and simultaneously they tend to raise triglyceride levels while lowering HDL. That's your protective good cholesterol. The cumulative result is a metabolic profile that is pushing your body in exactly the wrong direction, year after year. There's also the weight issue that almost nobody connects to the medication. Many long-term beta blocker patients gain weight without changing their eating habits at all. The drug modestly slows your resting metabolic rate. Combined with reduced physical activity from fatigue, the pounds accumulate quietly and steadily over months and years, and patients blame themselves entirely. They think they're eating too much, moving too little. Sometimes the drug is doing the heavy lifting on weight gain. Now, does this mean everyone on the beta blocker will develop diabetes or gain weight? Absolutely not. People respond differently to every medication, but if you're already borderline, if your fasting glucose is creeping upward, if your doctor has mentioned the word pre-diabetes, this is worth discussing, because the medication in your pill organizer every morning might be making that metabolic trajectory steeper than it needs to be. I want to talk about something that gets far too little attention, even within cardiology specialty circles. I'm talking about falls, specifically the direct connection between beta blocker use and fall risk in older adults, and why this particular risk is so underappreciated. Here is exactly what happens physiologically. You've been lying down or sitting quietly for a while, watching television, reading, sleeping. Then you stand up quickly, maybe to answer the phone, or in the middle of the night to use the bathroom. Normally, your body compensates almost instantly and automatically. Heart rate ticks up, blood vessels tighten slightly, blood pressure stays perfectly stable as you rise. On a beta blocker, that rapid compensatory adjustment is blunted. Your heart physically cannot respond fast enough to the change in position. Blood pressure drops sharply for a few critical seconds, and in those seconds, you feel dizzy, lightheaded, or suddenly unsteady on your feet. That experience has a name: orthostatic hypotension, and in adults over 65, it is one of the most common triggers of serious falls. And a hip fracture in someone over 65 is absolutely not a minor inconvenience. This is critically important to understand. Studies consistently show that up to 30% of older adults who suffer a hip fracture will die within 12 months of the injury, not from the fracture itself, but from the cascade that follows: complications, immobility, pneumonia, blood clots, a chain reaction that starts with one wrong step. And here's the part that really concerns me. Most patients experiencing orthostatic hypotension don't even recognize it as a medical problem. They just feel a little dizzy sometimes when I stand up. They grab the counter. They sit back down for a minute. It passes. They never mention it to their physician because it seems minor. It passes quickly, and it doesn't feel like a symptom worth reporting. If that description sounds familiar to you, or to someone you care about, please write it down specifically and bring it to the next appointment. That moment of dizziness when you stand up is not something to dismiss. It is a clinical finding. It deserves a clinical response, and it may be directly, not indirectly, but directly connected to the medication in your pill organizer. Now, I need to be very direct and clear about something important, because I don't want anyone watching this video to walk away with the wrong message. Beta blockers are not bad drugs. In the right patient, for the right underlying condition, they are absolutely life-saving medications. I prescribe them regularly in my own practice, and there are specific clinical situations where stopping a beta blocker would be genuinely dangerous. First, if you have diagnosed closed coronary artery disease, meaning partially narrowed arteries supplying your heart. Beta blockers meaningfully reduce the workload on that heart muscle. They lower your risk of a heart attack by reducing how hard the heart has to work each day. That specific benefit is real and very well proven. Second, if you have already survived a heart attack, beta blockers are a genuine cornerstone of your recovery and ongoing protection. They protect the heart muscle during the vulnerable months after the event and measurably reduce the risk of suffering a second cardiac event. Removing them without a very carefully justified medical reason in that situation, that would be irresponsible and potentially very dangerous. Third, if you have heart failure with reduced ejection fraction, meaning your heart isn't pumping blood efficiently with each beat, certain beta blockers actually improve survival. Carvedil, metoprolol, succinate, bisoprolol specifically. In that clinical context, these drugs are not optional extras, they are essential to management. Fourth, if you have certain arrhythmias, atrial fibrillation is a common one. Beta blockers help regulate and control your heart rate day to day. They reduce the risk of dangerous rhythm disturbances and help keep the heart beating in a controlled, manageable pattern that is genuinely valuable. So the question is never as simple as, are beta blockers good drugs or bad drugs? The answer to that question is always, it depends. The right question is always, what exactly is this specific drug doing for this specific patient today, given everything modern evidence now tells us? That is the conversation worth having with your doctor, and I'm about to give you exactly what you need to start it. So if beta blockers are no longer the recommended first choice for straightforward, uncomplicated high blood pressure in someone over 60, then what is? Current evidence points very strongly toward two major drug classes. The first is calcium channel blockers, drugs like amlodipine being the most common example. These drugs work by directly relaxing the muscular walls of your blood vessels, making it physically easier for blood to flow through them. Critically, they do not interfere with your heart's ability to speed up during exercise, and they don't raise your blood sugar levels. Studies, including the ASCOT trial specifically, show they reduce stroke and heart attack risk more effectively than beta blockers for uncomplicated hypertension. In patients who don't have underlying coronary disease, heart failure, or arrhythmia for that population, the difference in outcomes is genuinely significant. The second major class is ACE inhibitors and ARBs. Common examples include lisinopril, ramipril, losartan, and candesartan. These medications work by blocking a specific hormone system in your body called the renin-angiotensin system, one of the primary drivers of elevated blood pressure. These drugs also carry meaningful protective effects specifically for the kidneys, which becomes increasingly important as we get older and kidney function naturally declines, and they carry what we call a cleaner metabolic profile. They don't promote insulin resistance, they don't raise triglycerides, and they don't cause weight gain. Now I want to be very clear about something. I am not your personal physician. I'm not telling you to go home and switch your medication today. Your specific history, your specific test results, your specific conditions, those belong in a conversation with a real doctor who knows your case completely. But if you are over 60 on a beta blocker, purely for blood pressure, with no history of heart attack or heart failure or arrhythmia, it is entirely and completely reasonable to sit down with your doctor and ask directly, is this still the best evidence-based option for me right now? That is not being confrontational. That is being an informed patient. Any physician worth their degree will genuinely welcome that kind of engaged question. But now, and I really cannot stress this next part enough, I have to say something critically important before we go any further. Do not stop taking your beta blocker on your own. Not tomorrow morning, not after finishing this video, not after reading something online. Please, your body has physically adapted to this medication over many months or years of continuous use. That adaptation is real, and it matters enormously. Your heart, your blood vessels, your entire nervous system, they have all adjusted and recalibrated around the constant presence of this drug in your system. When you suddenly remove it, there is a documented rebound effect. Your adrenaline receptors blocked for so long suddenly become intensely hypersensitive. Your heart rate can spike dangerously. Your blood pressure can surge to very high levels extremely rapidly. And in some patients, particularly those with underlying coronary artery disease, they may not even know they have. That sudden rebound can precipitate a serious cardiac event. This is not a theoretical risk that I'm mentioning as a precaution. It is well documented in the medical literature. It happens, and it happens fast. The correct and safe way to come off a beta blocker, if that is the decision you and your doctor carefully reach together, is gradually. The dose is reduced incrementally in measured steps over several weeks. Blood pressure and heart rate are monitored carefully throughout the entire process. In most cases, a replacement blood pressure medication is actually started before or during the taper, so your pressure stays under control the entire time. This is a medical process. It requires physician involvement. It requires an explicit plan, and when it is done properly, absolutely can be done very safely. So please take everything you've learned today and bring it into a structured conversation. Do not make a unilateral decision about your medications at home alone. Let me tell you what I think about sometimes on the drive home after a long day in the operating room. There are an estimated 40 million Americans over 60 taking beta blockers today, a number that is almost impossible to fully grasp. A meaningful portion of those people are taking these drugs for uncomplicated hypertension only. No heart disease, no heart failure, no arrhythmia on record, just elevated blood pressure and a prescription that was written years ago and has been auto-renewed in the system ever since, without anyone reviewing whether it still makes sense. How many of those 40 million people are exhausted right now, genuinely tired, and believe with absolute certainty that it's simply their age? How many have quietly stopped taking evening walks because the stairs became too difficult? How many have abandoned activities they used to enjoy? How many are sitting right now with fasting glucose numbers that are slowly climbing, not knowing their medication is actively making that worse every day? And how many have grabbed the countertop in the dark, studied themselves for a moment, and then gone back to sleep without mentioning it to anyone? That is what genuinely keeps me motivated as a physician. Not the dramatic emergency cases, not the operating table. The slow, invisible erosion happening quietly in people who are doing everything right, taking their medication faithfully every morning, following instructions, being model patients, and still slowly losing ground. Here is the single most powerful and practical thing you can do after watching this video today. Write down this exact question on paper. I have been on a beta blocker for blood pressure for X years. Given my current conditions and today's evidence-based guidelines, is this still the best medication for me? That one specific question at your next appointment, hand it to your doctor if you need to, could be the most important health action you take this year, because medicine is not static. The best physicians update their thinking as evidence evolves, and the best patients actively help them do it. Take care of your heart. Being a well-informed patient is not being difficult. It is being your own best advocate. Consult your physician before changing any medication.